Good morning, everyone. Thanks for having us as the first Grand Rounds this year. I'm very excited to introduce Dr. Tony Rosen to give us Grand Rounds this morning. Dr. Rosen is coming from Weill Cornell Medical College and the New York Presbyterian Hospital, where he works as an emergency medicine physician and is an expert in elder abuse research. Dr. Rosen completed his residency training there at Cornell in 2014 and then completed a geriatric emergency medicine fellowship in 2016. He also did his medical school at Cornell and has an MPH from UCLA. And Dr. Rosen and I met in 2014 when he received the Jumpstart grant to look at patterns of elder abuse injury, and very nicely hired me as his research manager and helped get me started in the field. After the Jumpstart, Dr. Rosen received the BSIN to expand the research that we had started and prospectively enroll physical elder abuse victims. Oh, sorry. Touch screen. Spoiler alert. Okay. Apologize. And then recently he received an R01 from NIA to explore healthcare utilization among elder abuse victims using Medicare claims data and data mining and machine learning approaches. Dr. Rosen has also been incredibly one of the biggest leaders in our field in developing elder abuse consult services, and that's why they all have come out to join us and help teach us how to do this and start our own elder abuse team. Dr. Rosen is also a leader in geriatric emergency medicine, serving as the prior president of the Academy of Geriatric Emergency Medicine, the Geriatric Emergency Care Applied Research Task Force, the Board of Governors for the new Geriatric ED accreditation process, and is a core faculty member of the Geriatric ED Collaborative. So Dr. Rosen's resume is very long, and so we were very fortunate to have him this morning joining us. So thank you, Dr. Rosen.
Thanks very much, Dr. Blumen. A lot of that is a little overblown, but it's certainly exciting to be here. Myself, I'm having a great time, and my colleagues Ronnie LaFaso and Sunday Clark, who are also here from the East Coast, are also having a great time, and we're really, really excited. As you can see, I have no financial conflicts of interest to disclose, but just as Elizabeth said, we're lucky enough to be the beneficiaries of quite a bit of support from public and private funders. So greetings from New York. This is our hospital. You can actually see it in the K of that New York greetings, and we're right on the East River. Our ER is pretty busy. Our geriatrics clinic is, according to Ronnie, very, very busy. The Center on Aging there. And so we're excited to be here, but particular thank you to Dr. Blumen. We were actually just reminiscing last night. We have been collaborating since 2014, right when Elizabeth graduated from public health school. She joined our team and we interviewed no one else. When we met her, we thought, oh my God, this is amazing. And we were actually extraordinarily, our expectations were much lower than actually her extraordinary. She was basically like a senior colleague from the very day that she joined, and continues to be a real national and international leader as she pursues her medical training and her marriage and motherhood and all the exciting things. So it's really exciting for us to continue to work with you as we have. And a lot of what I'm going to talk about, and I will try to embarrass Elizabeth not much, but a lot of what I'm going to talk about is stuff that Elizabeth has absolutely been a leading part of. And so thank you very, very much. And also, we're here for a couple of days thanks to the work of lots of people, Elizabeth and Beth and Dan Lindbergh and many, many folks, but thanks for everything that you're doing. So we'll start with a case, and I'm an ER doc, so we tend to always start with cases in Grand Rounds so we can sort of orient each other. And I gave a similar talk to this, or frankly, a very similar talk to this yesterday to the emergency department, but I'll try to sort of focus on some things today that are a little bit different for folks that work in clinics. So in this particular case, there's a patient that comes in with a fall. They came in via EMS to the emergency department. They tripped on a wet rug in the bathroom. Patient struck her head and face on the side of a sink. Didn't lose consciousness, and the daughter reports that she was not assisting her mother, but witnessed the fall from the hallway. EMS was called, and Mrs. R was ambulatory on scene when they arrived. She had recently diagnosed mild cognitive impairment and lives with her adult daughter, who's the primary caregiver. The history is provided almost exclusively by the daughter, who notably interrupts whenever Ms. R attempts to contribute. Physical exam, she's mildly cachectic appearing, but well-groomed. She has ecchymoses, bruising in the periorbital area bilaterally, with the left eye swollen nearly shut, tenderness in both maxillary sinuses, bruising on her left cheek and on the external aspects of the upper arms. And I know, before I go any further, I know that this patient sometimes actually presents to clinic rather than to the emergency department. And I suspect that given this presentation, you would likely send them to the emergency department for our evaluation. But I'm going to continue, and as I continue on the emergency department evaluation, I want you to think about sort of some of the things in clinic that you might be thinking about for this patient. On imaging, which we got in the emergency department, she had an acute left zygoma fracture, an acute displaced nasal bone fracture, an age-determinant right zygoma fracture, and an acute right ulna fracture. Next steps in our emergency department, we have social workers. Just as you do at the university here, we have social workers available in our emergency department 24 hours a day. And social work evaluation, Ms. R's daughter continues to report that the injuries are due to a fall. And Ms. R agrees when asked directly. But when Ms. R is questioned alone in the radiology suite, and again, in a clinical setting that you have as an outpatient, you want to be thinking about the bathrooms. You want to be thinking about the evaluation where you're able to take height and weight in a private area, in an area where family don't usually go. Because then she admits to frequent verbal and infrequent physical abuse by her daughter. Her new story is that her daughter was insisting that she sign papers to allow her control all of the banking and finances. They argued, as they do frequently, and the daughter struck her twice in the face with Ms. R's cane. After the decision is made to admit Ms. R to the hospital, or in your case, to transfer the patient to the emergency department, for a safe discharge plan, additional testing is done, and she is found to have multiple old rib fractures, to be anemic, and to have low albumin, suggesting poor nutrition. Another quick case, Mr. G is not himself. Again, I'm an ER guy, so this is an ER case, but these guys tend to come to clinic as well. Hasn't been acting normally for a couple days. Hasn't been getting out of bed as he usually does and eating less. Again, I know this is a very uncommon geriatric presentation, but just bear with me. No fever, no cough, no other complaints. Also hasn't been taking all of his medications. The grandson who lives with the patient is at bedside, and he called EMS. Patient has advanced dementing illness and is unable to contribute to the history. Vital signs, heart rate 81, setting 93% on room air. The respiratory rate is the house 18, so who knows what it is, right? And the temperature is 35.7 rectally, so or orally rather. So this is a patient that is hypothermic. Physical exam done by us in the hallway in the emergency department. Hopefully that's not something that is a problem in the clinic. He's moaning. He's ANO times 0. He has dirty clothing, bronchi at the right lung base, and trace edema maybe at the ankles bilaterally. Imaging and labs, the chest x-ray can't rule out a right lower lobe pneumonia. I feel like I've seen that read maybe about 100,000 times. White blood cell and lactate are not elevated. Creatinine's 1.4, and the BUN suggests dehydration. Sodium is not abnormal. Next steps here in follow-up, the medical student brings the ACR to the team. And again, this is a little bit different in the emergency department, but I'm going to talk about it from a clinical setting as well. And because when a patient comes to the emergency department, most of those patients have had a home visit. In fact, they had a home visit 10 minutes ago. And that home visit was conducted by EMS that has a lot of information that us as ER doctors or you as clinic doctors don't necessarily have. And so the ambulance call report says that the apartment is very messy, filled with boxes, vermin infestation, foul odor, very cold, the heat's not on. Refrigerator's empty, multiple half-filled pill bottles, some prescribed years ago. The grandson yelled at the patient to be quiet while EMS was loading him onto stretcher. So this home component really changes the picture of what's going on with this case follow-up. When providing personal care, the nurse and tech identify additional physical findings, these toenails, this mouth, and pressure sores with some stool. CK is elevated to 7,400, and though the patient is documented to be on Dilantin and DIG, the levels are 0. So I wanted to give ER cases because we can see a little bit more, but I'll talk throughout this about how we can think about this as clinicians in all settings. Elder abuse, mistreatment of an older adult aged greater than or equal to 60 is typically how we talk about it. Of course, in Colorado, you're mandatory reporters for folks when they are 70 and older. By a person in a position with an expectation of trust, or when an older adult is targeted because of age or disability. It may include physical abuse, sexual abuse, neglect, psychological abuse, financial exploitation, and unfortunately, many victims suffer from multiple types of abuse concurrently. Unfortunately, and I think that it's less important for me to emphasize this to a geriatrics audience than it is for a more general medical or emergency medicine audience, but this is really common. It's a lot more common than we think, and it's a lot more serious than we think too. We think that as many as 10% of older adults living in the community experience abuse or neglect each year, and perhaps more than 20% of older adults living in skilled nursing facilities. And the limited literature that we have suggests that victimization increases mortality, nursing home placement, worsening of dementia, depression, and also exacerbations of chronic illness. Despite this, it is dramatically under-recognized and under-reported. As few as 1 in 24 cases are identified, we think, and ultimately the morbidity and mortality associated with this is closely associated with delay in diagnosis and intervention. So this is where we are. Maybe the healthcare visit might be an important opportunity to identify and intervene. After all, for many of these older adults, the evaluation by a healthcare provider may be the only time that an abused older adult leaves their home. And in some cases, healthcare providers evaluate patients in their home, particularly geriatric clinicians. But despite this, the literature that we have and some of the work that we've done suggests that healthcare providers seldom read, almost never identify and report elder mistreatment. And there are certainly barriers and disincentives. Lack of time to conduct a thorough evaluation in a busy clinic visit, lack of awareness or inadequate training. And I'll pause on this for a second to say that hopefully this is helpful. And I know that elder abuse is a part of the core geriatrics curriculum. In fact, colleagues and I have written the GRS chapter, but I think that even geriatricians sometimes don't feel comfortable with this topic. And I think it's really important to make sure, and this is for the fellows, if there are fellows listening, that this is something that you're really comfortable with at the end of your fellowship. Fear and distrust of the legal system, denial by the patient, him or herself, ambiguities surrounding decision-making capacity in victimized older adults, absence of a protocol for a streamlined response, and difficulty distinguishing abuse from accidental trauma or illness. And this is what I'm going to start with. And what I started with when talking yesterday is challenges in what you might call elder abuse forensics. It turns out, and this is something that you're probably not as aware of, but it turns out that for ER docs, and if you think back to medical school, forensics is at the absolute cornerstone for child abuse detection. We all learned a lot about this in medical school, and we all thought very seriously, gee, this injury isn't what's supposed to happen when you fall off the monkey bars. And that's sort of a really important part of how we evaluate injured children. And that actually started in 1962 from the Battered Child Syndrome, which was a very influential article in JAMA written by Henry Kemp, who was actually here at the University of Colorado. And since then, there's been an extraordinary amount of research. Much of it led here. There's now the Kemp Center, which Dean Krugman led for many years, and Dan Lindberg, who's an emergency physician, is now deeply involved in as well. So forensics has been really important for child abuse, but elder abuse, not so much yet. In fact, first, confidently identifying elder abuse is way harder. The physiologic change in their bones that may cause easy bruising, and the varied functional status of older adults make it much more challenging. Also, there's much less evidence. Again, I don't think you would have done such a literature search, but if you would find that there's over 1,000 articles systematically examining child abuse-related injuries, evidence to support our practice. However, when we started, and when I say we, I mean including Elizabeth, when we started, when myself and Ronnie and Sunday and Elizabeth started, there were more than 1,000 peer-reviewed articles, and in elder abuse, there were 5. So our objective was to identify injury patterns associated with physical elder abuse to help busy providers clinically. And if you think about it, the methodologic challenge was, well, how are we going to find elder abuse cases to study? After all, we never identified. So maybe we could start a study and maybe we'd be done by the year 2350 or 2400. And so this was the idea. And frankly, this was Ronnie's excellent idea, was, hey, we work closely with the DAs. Actually, Robin works closely with the DAs in her community. We work closely with the DAs, and they've got legal files, and those legal files have got photographs, and those legal files have got medical records. And so we actually got ID badges and went to the 18th floor of the Brooklyn DA's office, and we looked in these charts, and we evaluated these cases, these legally adjudicated cases where abuse was certain, or at least as certain as it can be, because the perpetrator was prosecuted and convicted or pled guilty. And interestingly enough, we also had to do a few things. We developed a standardized protocol for photographing injuries. This was actually led by Elizabeth Blumen. And we developed a comprehensive classification system and taxonomy to describe geriatric injuries in order to conduct this research. But if you think about it, it's not enough to know what injuries are common in physical elder abuse, because physical elder abuse is still pretty uncommon. And falls, well, they're really common. What we really need to know is what's common in physical elder abuse, but not common in falls. And so we developed a case control study comparing injury patterns, physical findings, forensic biomarkers, and photographic injuries between physical elder abuse victims and patients presenting to the emergency department. And here's what we found. Physical elder abuse victims were much more likely than unintentional fallers to have these injury patterns. The first, and this is one that's emphasized, I think, by Elizabeth, and one that we think is really helpful, maxillofacial or dental neck injuries, so injuries around the face, combined with no injuries on the upper or lower extremities. You're allowed to get injuries on your face when you fall down the stairs, but it's weird to get injuries on your face and then nothing on your legs, which are much more easy to injure. Also, we found injuries to the left cheek or zygoma, the left part of the face, were much more common. In fact, they were very, very uncommon in falls, but very common in elder abuse. And the reason for that, this is similar to intimate partner violence and child abuse, is that our assailant is often right-handed using their fist, and the left face is exposed. But also, our job, we thought, was to start to look for highly specific injuries, the kind of injuries that would really say, gosh, I'm really concerned. And so we were looking for things that just didn't really seem to happen in falls. And we found 2 things. We found the ear. There's really no bony prominences around the ear, so it's really hard to injure the ear if you fall. And perhaps most importantly, the neck. There are no bony prominences in the neck. And when you fall, if you think about it, and I think we talked about this yesterday, your neck is protected by your head, and your neck is protected by your shoulder. So the only real way to injure your neck on a fall is to fall against the edge of a table or fall against the edge of a refrigerator. That already sounds to Robin and me like, a little suspicious. And so, again, we are very, very, very much at the beginning of elder abuse forensics, but we're starting to think about how we can differentiate these among the sort of large number of falls that we see in the emergency department and that you see in your clinic visits as well. And our plan is to use this, just as Elizabeth said, we're now looking at cases prospectively and hoping to derive a clinical decision rule to assist healthcare providers. Again, to make sure that folks can say, well, you're saying this is a fall, or the person standing next to you is saying this is a fall, but I think it makes sense for us to get you alone and ask some more questions and make sure that we're not missing something. So I also wanted to give some tools, and for those of you that have been in our two-day session, you may have already seen these slides a couple of times, so I apologize. But we really do believe that part of elder abuse detection is visual diagnosis. What are you looking for? What are the things that should trigger concern? And Ronnie LaFaso and I have given this part of the lecture all over the country to general internists, to emergency physicians, to non-physicians, to adult protective services workers. And we think it's really important to think about what are the physical signs that you should be looking for. Warning, there's some graphic content. Most of us are used to graphic content, but just to let you know. So again, some falls are actually physical abuse. So bruising in atypical locations, not over bony prominences, over the lateral arms, back, face, ears, or neck. Here are some images of that. Patterned injuries, bite marks, injury consistent with the shape of a belt buckle, fingertip, or other object. Here's some fingertips on the forearm, which is a common injury that makes us concerned, and a patterned injury. Wrist or ankle lesions or scars, suggesting restraint. Again, this is unfortunately more common than you'd think, particularly for older adults that have dementing illness and are difficult to care for. Burns. Particularly stocking glove pattern suggesting forced immersion or a cigarette pattern. So a couple things about this. The first is we're a burn center. So we see quite a few burns in our place. And I kind of feel like virtually any burn in an older adult, I want to know more. And I want to be thinking about, but these particular patterns are particularly concerning. And for those of you that may remember medical school, you are probably thinking to yourself, gosh, this does sound a lot like child abuse. And the answer is, it does. It is similar. Some of these things are similar to what you look for in child abuse. Again, multiple fractures or bruises of different ages. Multiple fractures of different ages is concerning. Multiple bruises are harder to age. The literature suggests that pretty clearly that you can't age bruises based on color, but you can age bruises based on multiple photographs over time. And finding things that are of different ages is concerning. Traumatic alopecia. If you don't know what that is, that's when someone pulls out a clump of hair and you end up with a scalp hematoma. That doesn't usually happen unintentionally, and it's something to look for. Subconjunctival or retinal ophthalmic hemorrhages. These are obviously very specific in child abuse, but are also suggestive in elder abuse as well. And intraoral soft tissue injuries. Again, often from force feeding. They can be the sort of same type of frenulum tear type of injury that you might see in a child. Sexual abuse, genital, oral, or rectal trauma, including erythema, bruising, and lacerations, and evidence of sexually transmitted disease in a patient not thought to be sexually active. Neglect. And I think this is what we see most commonly. This is the most challenging because it is, most of these findings are very nonspecific. And I'll talk a little bit about that in a moment. But cachexia and malnutrition, muscle wasting, temporal wasting, sunken eyes, dehydration, dry mucous membranes, skin tenting, severe constipation, fecal impaction, pressure sores, and decubitus ulcers. And I'm going to pause on this. We had a very rich discussion about pressure sores and decubitus ulcers yesterday. Ultimately, as I learned from Ronnie, you can receive care 24 hours a day from your spouse, who is a nurse practitioner, and still, despite that excellent care, you can develop pressure sores. And so the presence of pressure sores is not, in our opinion, definitively suggestive of neglect. For those of us that have done neglect consultation services, it's a pretty common reason we get called. But it is not necessarily suggestive of neglect on its own. So what are the things that we're thinking about? What are the things about pressure sores that concern us? Things like maceration surrounding a pressure sore, clear pore care, stool in a pressure sore, pressure sores in areas like the heel and the ankle that are both atypical and suggestive potentially of restraint, multiple pressure sores at different stages. So ultimately, pressure sores are something that we really need to focus on and we really need to think about, but it isn't as easy as pressure sores are suggestive univocally of neglect. Poor body hygiene, unchanged diaper. Again, this is something that I try to emphasize, particularly to my ED-based colleagues, but I think it's worth pointing out to clinicians in the clinic as well, that often you don't see the patient right away. Someone else helps clean up the patient, put the patient in a gown, may even change their diaper in some cases. And if you don't make sure to empower that person, they might not say, you know, I didn't take off one diaper, I took off two because there was a diaper on top of a diaper. And that's important to know. Dirty, severely worn clothing, elongated toenails. Again, one of the things that I was taught by a colleague, Mary Mulcair, when I was a resident, was that in the ER, no full evaluation of an older adult is complete unless you look at their feet. And I think you can learn a lot about the feet of an older adult. Learn a lot about an older adult looking at their feet. Poor oral hygiene, same thing. You can't complete an evaluation of an older adult in the emergency department or in the clinic by not looking in their mouth. It might tell you a lot about the kind of care that you need to provide. Imaging findings. So again, when we think about elder abuse forensics, we think about sort of child abuse 60 years ago. And if you think about child abuse, radiologists, it's like the core of their practice is identifying potential non-accidental injuries in children. In fact, I think I mentioned this yesterday, it's 15% of radiologists' boards is child abuse detection. So what about elder abuse? Well, the first thing that we did when we thought about elder abuse was we asked radiologists. Elizabeth and myself did a qualitative study with Sunday and Ronnie's help of the radiologists in our clinical environment, and here's what they said. You know, I've been doing this for 17 years, and no one's ever asked me about elder abuse. No one's ever even brought it up to me as a possibility. And then you say, well, do you think there are imaging correlates for elder abuse? And the answer is, well, sure there are. Of course. So that's where we are at the very beginning. These are folks that would like to be helpful, but we're at the very beginning of this process. So how can you, as geriatrics clinicians, think about this process? Certainly you order x-rays for patients. Think about fractures at different stages of healing or a reported history of injury out of proportion to the observed injury. So in other words, did they roll off a bed that's like 5 inches off the ground and they have injuries suggestive of a high energy mechanism? Again, that's something that our radiology colleagues can help us with, but they can only help us if we help them. And this is really a problem for the ER. It may also be a problem for you guys, but basically, there were a lot of x-rays on a shift. And often when I put in the history, I think put things like fall, elbow pain, pain. And I'm really not helping the radiologist. As we were talking earlier, we talked about this yesterday, that you really need to let the radiologist know what you're looking for, often via phone, in order to make sure that they know and that they can be as helpful as possible. And we have developed this list based on our qualitative interviews of radiologists of potential findings suggestive of elder abuse, but this is very preliminary. We're actually right now doing a multi-center case series to try to provide a little bit more evidence, so to be continued. But we really do think that our radiology colleagues and imaging can be an important part of abuse detection. And frankly, again, since we're your experts, we're you're geriatricians, you can think about things like ulcers, brain volume loss, multiple nutrition. So there are some things that aren't even related to physical abuse, but there are some findings related to neglect that our radiology colleagues think are possible as well. Medical and laboratory markers. This is actually some of the work of Dr. LaFaso. Unfortunately, there is no laboratory test to definitively detect abuse. No big surprise. As far as I know, there is no one working on such a test either, I'm afraid. But despite that, lab tests may suggest, the routine labs that you order or that we order in the ER may suggest malnutrition, dehydration, anemia, hypothermia, hyperthermia, and rhabdo. And we often point out that though albumin is routinely ordered, we will often recommend pre-albumin because that's sort of a more accurate assessment of recent nutrition. An older adult with suspicious bruising and normal coagulation studies may have abuse-related injuries. And so think about when you see a patient with bruising that you think maybe senile purpura, maybe something more suspicious, what are their coag studies? Are their coag studies suggestive that they're likely to bruise or not? Blood or urine tests for medication levels, drugs, and toxins. And this is another way that we can think about neglect. Low or undetectable medication level may suggest intentional or neglectful withholding or diversion. And one of the things that we're starting to see that we've seen now, unfortunately too commonly, is older adults that present to clinic in severe pain. And if you were to do a test, you were to find that they are not taking their opiates, that rather their caregiver is diverting their opiates for either their own use or to sell. And elevated medication levels may suggest intentional or unintentional overdose. And I think one of the things that we were talking about yesterday is that there is here a very broad panel that can be ordered that can look at hundreds of medications, even things like Benadryl. Because I think one of the things that we know that's a not uncommon approach for caregiving is to try to surreptitiously add sedating medications to an older adults. And the presence of toxic medication not prescribed may indicate poison. So as Dr. Blumen mentioned, we're trying now to get beyond forensics. This article here, and I think I mentioned it yesterday, this article here talks about Allegheny County and how they're using machine learning with administrative data to try to identify among child protection reports, which young people are in real danger. And again, we're way behind child abuse as we always are, but that's something that we're really excited about. Can we use advanced algorithms using patterns of healthcare usage? In other words, do our elder abuse and neglect victims use the healthcare system differently? Probably more us. When they use you guys, it's probably without a whole lot of notice. They often miss your appointments. They often don't take the medications as directed. And is it possible to identify at-risk adults using Medicare data? Because again, Medicare has a huge amount of information about each one of these patients, and can we mine it to find patients that are at particular risk? The short answer is, we hope so. we're working on a team-based approach. So one of the things that I think we focus on in the emergency department, and I wanted to bring this up in the emergency department context, but also for your work, is that it's hard. People are actively trying to conceal this in many cases. And so identifying this in a patient that comes in with abdominal pain or chest pain or some other completely unrelated chief complaint takes everybody. EMS sees inside the home. Triage might meet the family and then the family leaves. Nursing, our techs and our radiology techs, we've actually talked a lot in emergency departments about actually evaluating the patient in the radiology suite. Because the person that's standing next to them the whole visit and won't leave their side, they're not going to go in with them when they get an x-ray. Our radiologists, as I mentioned, our social workers, I'm going to talk a little bit more about our social workers, but I think our social workers and care coordinators are they're awesome, and they're the absolute critical piece here. And so what we tell folks when we talk to ER folks is it's hard. So everyone needs to be empowered to contribute. Everyone from the clerk to the front desk person to everyone that's involved in the care of the patient, people that are watching the waiting room. Everyone needs to be empowered to notice things and to tell people when they notice things and to be taken seriously when they notice things. And I think that as we say in emergency medicine, it's true in the geriatrics clinics as well. Often things that happen in the waiting room can impact what's going on. If you see an interaction in the waiting room that's concerning, it'd be great to know about that. And from my perspective, in a multidisciplinary geriatrics clinic, and I hope that most geriatrics clinics are becoming even more multidisciplinary, though I know it's often a challenge, every member of that clinic, from the social worker to the psychiatrist to the if there's a physical therapist or an occupational therapist that's involved in that clinic, any one of the team members and each one of the team members can have a real big impact on thinking about this from their own perspective, watching this, and having an extra set of eyes. So one of the big things about elder mistreatment is the home environment. And last I checked, we don't generally see patients in the home, except that we are doing it more and more. When I presented yesterday to the emergency department, I reminded them just how important the EMS home visit is. But for you guys, in some ways, telehealth creates a really exciting opportunity to see inside the home. And I'm sure as geriatricians, you're already doing this. But from my perspective, a geriatrics telehealth visit should include a trip to the medicine cabinet and a trip to the refrigerator and a few other things to sort of see what the living environment is like and watching. And so from my perspective, telehealth offers an opportunity when caring for geriatric patients to look and think about these things. Is this patient living in a safe environment? Are there things that make me concerned? Also, many of the patients for whom you guys provide care also see visiting nurses and other folks that come into the home health aides. And so these are other folks that might be able to tell you about the home environment. Often, I'm sure Robin has the same experience, often it's VNS triggering an ED visit that sort of starts a lot of the process of identification in a lot of these cases. And so keep in mind that there are eyes in the home and that telehealth makes it easier for you to get more information about your patient than you had before. Concerns about the older adult and caregiver interaction, whether it's in the waiting room, whether it's during the part of the visit that you manage, whether it's the technician or nurse that's conducting the weight, height, and other routines. Here are some things to think about. If the older adult and the caregiver provided conflicting account of events, if the caregiver interrupts or answers for the older adult seems fearful or hostile towards the caregiver, if the caregiver appears unengaged, inattentive, in caring for the older adult. Concerns from the medical history, and I'm not going to read this whole list, but here are a few things. Unexplained injuries, delay between onset of medical illness or injury and seeking medical attention, and again, and this last is probably the most important for your clinical practice, non-compliance with medications, appointments, or physician directions. So what about elder abuse and COVID-19? We all of us sort of that were thinking about research sort of became even more focused on how COVID-19 impacted the area of focus that we had. And again, I think this probably comes as no surprise, but the limited research that we have suggests that, of course, there are increased risk factors for both older adults and caregivers during that initial surge, and frankly now again during the surge that we're in the middle of now. And there's more limited response from community-based resources. There are many community-based resources that aren't now going into homes or going into homes much less frequently. Senior centers are closed. And so as a result, there are less opportunities to identify this, and there are less people to support and prevent it. Also, there's less visibility into nursing homes as a visitation is curtailed or limited or stopped. So unfortunately, in elder abuse, we think that elder abuse is both likely more common during COVID, but even less frequently identified, making our responsibility as clinicians even greater. Because without us, this is probably not going to get recognized during this time. And when you think about your panel of patients, you can say, among my panel of patients, who are the most vulnerable? Who are the ones that I think I'd be most concerned about, given their living situation, given their healthcare utilization, given their family situation, and so on. So a bit about management. Again, you guys are experts, but I think there's a couple things that I wanted to emphasize. Documentation. Documentation is critical when you see these patients. Remember, your documentation is not only medical documentation now, it may be forensic documentation. It may be critical for this patient to get justice in the future. And so detailed, specific documentation of all physical findings. Now that we have Epic Haiku, as we were talking about yesterday, that should be much easier to use body maps and photographs. Please use them liberally. That's really, really important. It's important also, as we say in emergency medicine, to document everything. Even bruises that may not seem clinically significant may be forensically significant. Ensure patient safety. And so I think this is one of the things as a geriatrician that you think to yourself, well, okay, what's next? Well, the first thing that you can do is you can consider transfer to the emergency department. In fact, Ronnie has transferred patients to the emergency department in the past. If you are concerned about their immediate safety. Prevent contact with the abuser if there's immediate danger. You can arrange alternate living arrangements or emergency shelter. And one of the things you can do in your hospital and health system is if the abuser is also the healthcare proxy and decision maker, then that's something that you want to involve your ethics and legal colleagues. And we created, Tim Potts-Mills at UNC and colleagues and myself created what we call the STOP criteria. And again, I think these are hopefully helpful. Hopefully these are uncommon, but these are helpful, hopefully, to think about cases that we really shouldn't send back to this previous living situation. If there is S, sexual assault with ongoing risk, T, threat, concern for or stated threat of physical injury. O, no access, neglect with ongoing risk for insufficient access to shelter, food, medication, or medical care, and P, physical abuse with injury and ongoing risk. These are patients, and again, it's uncommon, hopefully, but these are patients where we really should be thinking about an alternative living situation than where they're living now. But guess what? A lot of patients, they don't want to listen to us. And so as a result, many patients refuse intervention. In the context of the emergency department, this is, I just want to go home. I agree I'm getting abused. I just want to go home. And you're saying, gee, I'm really concerned about this. I think I need to send you to the emergency department. And they're like, no, I need to go. I need to go. And if you think about it, and I presented this yesterday, if you think about it, when an 8-year-old says to you, and 8-year-olds have said it to me, you're right, this bruise is not from a fall off the monkey bars. This is my mom. She hit me last night, and then she locked me in my bedroom with no dinner. But I love my mom, and I want to go home. We say, sorry, as a society, we've decided that we're not going to let you go home until we are sure that it's safe. But then when that same person comes back at age 25 or 27 and says, this bruise on my belly is not because I'm clumsy. It's because of my partner. And he threatened me with a knife last night. But I love my partner, and he told me he's going to change, and I want to go home. We say, you have a right to make that decision. And we know it's risky, and we want to give you safety planning. And we want you to know, in our emergency department setting, we want you to know that we are always available, open 24 hours a day, 7 days a week. But you have a right to make that decision. The challenge with older adults is that I know plenty of 95-year-olds who I've cared for who can absolutely make that decision. And I also care for, perhaps more than you guys do because you often send them to us, but I know plenty of 70-year-olds who can't, or who could a month ago, or last Tuesday, or even an hour ago, and can't now. And so from our perspective, the first thing that we would need to do, and we talked about this a lot yesterday, I think we're going to talk about it again today, is you need to determine their capacity to make this decision. Of course, capacity is decision specific, and you need to determine their capacity to make the decision to refuse additional medical care and leave against medical advice in this particular scenario. And psychiatric consultation may be helpful. It certainly can be helpful in an emergency department setting, and many geriatrics clinics have a psychiatrist who's either available via telehealth or often in the office. And so having them get involved may also be useful. But just as in any patient, the wishes of an older adult with decision-making capacity to return to an abusive situation must be respected. And you can educate about safety planning and the potential for escalation and provide appropriate referral materials. And I love social work. This is an opportunity to involve social work. If you happen to work in a clinic where social work is available, they are amazing, an excellent resource, but often we work in places that don't have social workers or social workers busy. And I wanted to just add this link in case you're not aware of it. It's called Aunt Bertha, believe it or not, findhelp.org. And you can put in your zip code, and then you can find available resources in many categories. And so if you're kind of at the end and social work is left for the day and you really want to give some resources to a patient, I think this is a website to keep in mind. And Beth and Alyssa, Beth is the wonderful social worker here on this program, and Alyssa is our social worker at Cornell, mentioned this website yesterday during their presentation. And of course, reporting to the authorities is appropriate. Here in Colorado, you are mandated reporters. And so you need to call the police and ultimately report to Adult Protective Services in any case where the patient is over 70. So again, for us, we think of elder abuse as over 60. And I know Robin in her practice also thinks of it in that fashion. And that's typically the way the law defines it. But here in Colorado, 70 is the age at which you're obligated to report. You can report concerns about a nursing facility to the Ombudsman and Department of Health. And here are some websites on how to report to APS in your community and information on mandatory reporting laws, which do change. Particularly, and this is of course particularly for the fellows who may ultimately practice elsewhere. Although I've heard that they want them to stay. But for fellows that may practice elsewhere, keep in mind that different communities have different reporting requirements and have different ways to report. And many physicians now actually work in multiple communities, even multiple states. And keep in mind that the way that you manage this may be different in different places. Again, if you have a social worker who works with you closely clinically, they're likely to be the experts. And so reach out to them and have them help you. Briefly, we're looking with colleagues throughout the country, funded by the John A. Hartford Foundation, at a comprehensive approach to elder mistreatment care in the emergency department. And there's a pragmatic trial ongoing on multiple sites. Hopefully we'll have some results from that in the coming months. And screening. I didn't actually talk about this yesterday, but I think this is an important thing that I wanted to talk to you guys about, because I think that their primary care screening for elder abuse is something that is an active question now. And obviously, screening has the potential to significantly increase identification. And there have been editorials in JAGS saying, this is common, this is really serious, this is dramatically under-recognized. Why aren't we screening for it? Why aren't we screening for it routinely? So a couple thoughts on where we are on screening. Because there are many geriatrics clinics around the country that are screening. But I would say right now, most geriatric clinics are not screening. A couple thoughts in general on where the literature is on screening at this point. First, a single safety question, that safety question that we all learned in medical school, do you feel safe at home or the equivalent, is unlikely adequate or appropriate for older adults. In fact, it turns out that literature in intimate partner violence suggests that it's actually not that sensitive, even in intimate partner violence. And so it actually is not adequate. But for older adults, though it's never been studied, we all think, gee, when an older adult is interacting with a healthcare provider, one of their biggest concerns is, you're going to put me in a nursing home. And so if you say, do you feel safe at home? The answer is always going to be absolutely, I feel safe at home. Don't take me out of my home under any circumstances. So fundamentally, unfortunately, a single safety question is unlikely adequate. Although you'll see that a lot of people will try to implement a single safety question. Targeted screening makes more sense, right? Rather than screening every single person, wouldn't it be great to be able to screen just the people that we thought were vulnerable? Turns out we're not there yet really either. It's very difficult to accurately identify high-risk patients, and targeted screening may miss victims. You may find people, but you're likely to miss people also. And so we love the idea of targeted screening, but we don't think that as a field we're there yet. And also, and I think most importantly, there is no evidence yet indicating either improved outcomes or negative consequences with screening. I think we were all raised as medical students, and I still give lectures in our family medicine clerkship on thinking about screening in the context of the benefits of screening and of the harms of screening, and taking a sophisticated look at the potential for screening not only to cause benefit, but also to cause harm. And that's pretty obvious in elder abuse, right? If you're screening for elder abuse and you find it, then you might create new problems. You might create retaliation. You might create a nursing home placement, other things that are undesirable outcomes. And so as a result, this is where we are. The U.S. Preventative Services Task Force just 2 years ago, or I guess now 2 years ago, updated their guidance for screening for intimate partner violence, elder abuse, and abuse of vulnerable adults. And they did not recommend elder abuse screening. And the reason was for an absence of evidence. Many of us are trying to generate evidence to think about whether this is a good idea, and if it is a good idea, how it might be operationalized. But I think as geriatricians, it's important to know that this is something that people are talking about and thinking about. And I think that the current approach, certainly of thinking about this and assessing for it, but whether or not people are going to move towards a more universal formal screening, I think that right now that's still a very active debate in the field. So I'll tell you now a little bit about why we're here. We were less focused on screening, but more focused on intervention. One of our concerns was, gosh, I don't know if we want to be screening for something if we can't do anything about it. And we also thought about child protection teams that we've been involved in as ER doctors. And there are over 1,000 child protection teams in the United States. Certainly, University of Colorado has one of the leading ones. But we knew of no ED-based elder protection teams. And so we created one 4 years ago called the Vulnerable Elder Protection Team. It's a consultation service available 24/7 because we're ER folks. And so ER is open 24/7 to assess, treat, and ensure the safety of elder abuse and neglect victims, while also collecting evidence when appropriate and working closely with the authorities. And we hoped that this would increase identification and reporting while decreasing the burden on ED providers. As you can see, as I pointed out yesterday, in the top right, there's that little button. If our ER folks could say, gee, I'm a little concerned, all I have to do is press a button, then they might be more likely to identify that, if I ask a question, then it's going to be more work. And so let's just get them out. So ultimately, that was our question, was could we increase identification and also decrease burden? Essentially, like child protection, could our ER colleagues say, I'm concerned about this, I'm going to call the team, and then I'm going to turn back to other patients and focus on heart attacks, strokes, trauma patients, ectopic pregnancies, that kind of thing. And so again, we unabashedly copied many of the elements of child protection teams. And I'll tell you a little bit about our evaluation so far. People have called us. In the first 2 years, we were activated in the ER 200 times, so almost twice a week. And also, we were activated 50 times by inpatient colleagues, even though we weren't actually staffed to provide any services to the inpatient folks and hadn't even told them we existed. And so it shows that it's out there and that people want assistance with this. And frankly, this compares to about 3 cases, maybe, that were identified in the year before we became involved. Also, the question, though, is, are we helping people? And here's where we are with that. And we're going to talk a lot more about that this afternoon. But among patients with high or moderate concern for mistreatment after our evaluation, in other words, after our evaluation, we were still concerned for abuse, neglect, or exploitation, 58% were discharged to a different place than they presented to the emergency department from. We are lucky enough to have a couple of elder abuse shelters or domestic violence shelters in New York City, and so a good percentage were discharged there. And also, among the patients that were discharged back to their home, we were able to add additional or new home services to an additional 23% of the total. So really 81% of the patients had either a change to the living situation or new or additional home services. And for our hospital administration colleagues, only 4 of these patients has returned to the ED for a mistreatment related issue. And again, as Robin asked yesterday, we don't know, we can't really compare that to the prior, other than to say that certainly these are patients that are thought to be very chronic users of the ED, and many of these patients were chronic users of the ED before our program existed. But we're here thanks again to all the amazing work of Elizabeth and Beth and many, many others, Carrie, many of the folks who are here, Robin, et cetera, because you guys are doing something similar. Our program was funded by the New York State Office of Victim Services. The New York State Office of Victim Services is the New York State administrator of Victims of Crime Act funds that come from the federal government. And those funds actually support the forensic nurse examiner program here and at hospitals around the country. They support most domestic violence shelters in the country. And we were lucky enough to be funded by them for our elder abuse team. And your team applied for funding from the Colorado version, the Colorado Office of Victims Programs, Office for Victims Programs, and has been generously funded to develop VESPA. And so that's really, really, really exciting for us. We feel like myself, Ronnie, Sunday, Alyssa, who's on the line, and Danny and Elaine from our team who are on the line, feel like we're already learning a lot from you guys. And we're really excited to work together to understand how we can build these consultation teams to be helpful, perhaps to inpatients, perhaps to outpatients, and also how we can evaluate these teams effectively to understand what interventions are working and what interventions are not. So from our perspective, we're delighted, and I want to thank again Beth and Elizabeth and Sarah and everybody. It's been really a great day and a half, and we're looking forward to today as well. But from our perspective, there are real opportunities here to intervene and real opportunities here to help vulnerable older adults. And we're really excited to be a part of it. Also, this is we designed primarily for ER folks, but I think it's actually just as useful for geriatricians. www.elderabuseenergency.org. We know that these are not cases that folks are going to see every day. And we also know that grand rounds, people sometimes don't remember much. But for your clinical practice, this is a resource that you can go to if you have a case in a clinical setting, that you can pass on to your trainees, that you can use in real time to find all of the links that I discussed are on this website and hopefully easily accessible. But it's a relatively new website, so send me an email if you think that there are things that can be improved. But hopefully this will be a helpful resource. and these are my kids. Today is the first day of school in person in New York, and so they are very excited but nervous. And so thanks very much.
Thank you so much. We're a little bit over time.
Oh, I'm so sorry.
No, that's fine. I think we reconvene at 9 up in 7,000. So just a chance for if anyone on Zoom had questions, please go ahead and put those in the chat. And then if anyone in the room has questions.
I do if you don't have from there, but.
Not yet, go ahead. So,
Okay,
yeah.
so, Tony, something I got really excited about when we talk about empowering others, one thought I had was that you mentioned the radiology techs, and we talked about how they might be able to talk to a patient, or a patient may say something to them in the privacy of the suite, but I also thought they're the ones who also get the patient in a state of undress for the film. And so we need to empower them to also say, hey, doc, and by the way, there's some bruising on her left thigh that we may, for whatever reason, not see or notice or examine in our exams. And I think that's really, especially for the outpatient setting, when we don't do the same evaluation in the ER. So I thought it would be really neat to be able to like go to the staff meeting of the radiology department specifically to give this talk and talk to make sure not just the guys who are reading the films, who may never actually see the patient, but those techs.
I think it's a really, really great point. Oh, sorry. To repeat, I think it's an excellent idea. What Robin was suggesting was that in the outpatient setting, the radiology techs also typically have a patient in a gown and might be able to do a more full skin exam than is routinely done by the clinician. And so they might be able to identify things that might otherwise be missed. And she thought it would be a great idea, and I certainly agree, to give a version of this presentation to the radiology techs so that they're looking out for this. In fact, we've talked in the past about if there were to be screening for this, maybe the radiology tech is the right person to do the screening in a private setting, in a setting that, again, I've talked to radiology techs and they say they are very, very busy. But doesn't it seem like they kind of have a lot of time where they're positioning the person and so on? It just seems like kind of a long time, a time where you could have a brief conversation without sort of slowing down the process. And so I think that's a really, really important opportunity.
And I think your word empowering is very important too. And I think to respect and to show the techs, we get it. You don't just place and shoot. You have a lot of other medical acumen. And the same for home health nurses. I am not utilizing my home health nurses enough in terms of that partnership. They call me when there's a problem with refills. They call me when they think the patient's blood pressure is higher than it should be. But that's another kind of Zoom staff meeting thing I want to try to get into is the home health agencies we tend to use predominantly, and actually give an elder abuse talk and ask them to really be more in communication and dialogue with us.
I completely agree. And again, I know I could talk about this for hours. I think the home health aides are a critical resource. I have a close friend, Tom Caprio at University of Rochester, whom some of you probably know. And we really think home health aides are a real potential resource. The challenge with home health aides is the reporting process. Because from their perspective, on the one hand, do they report to their supervisor? Do they not report to their supervisor? If there's abuse in the home, they're likely going to lose their job. It's all kinds of complicated issues from a home health aide perspective, but I couldn't agree more that that's a real important resource that we're not yet adequately empowering. And I also, it's a word that I chose, that we've chosen carefully, and we really agree that at the end of the day, this is a team-based job. Medicine is supposed to be team-based, and for something like this, we've got to empower all members of the team. We got to take people seriously. Like ultimately, what I would really love to have happen, though I wouldn't like to have happen, is for the front desk clerk to say, you know, while the patient and their caregiver were in the waiting room, I saw something kind of weird. And I wanted you, the doctor, to know about it. And for the doctor to say, thank you so much for telling me this. This might really impact how we care for this patient.
Our clerks do that very, very well because we have had that discussion in our clinic. not just for the geriatric, but for the whole, we're embedded with internal medicine clinic. It is amazing how often a clerk will come to us and say, I just want to give you a flag about the patient you're seeing at 10:20, blah, blah, blah. And I find that really, really important. And again, you're right, the reinforcement is, thanks so much. You can't believe how important that information is for me. Thank you for bringing it to me. This is a constant relationship builder as well over time.
There is a question from Zoom if we
Sure.
have time for that. So the question is, what processes are in place to ensure the best practices across hospitals doing this work are shared? And thank you for the great work.
Well, great question. And the short answer is we're getting there. We're getting there. I think that we're still at the beginning of even knowing what best practices are. I think ultimately, if there is a single best practice that we're trying to make sure is very widely disseminated, it's increasing recognition, increasing assessment, and confidence in management. However, we recognize that that's probably not where we want to ultimately be. Where we want to ultimately be is in a place where people have a streamlined response that they can be confident in. I think ultimately it's like anything. I'm very confident in managing PEs now because we have a PE team and we have a PE protocol and so on and so forth. And from my perspective, what we really need and we don't yet have are best practices across specialties in how to assess and then manage this confidently through protocols. Again, I'll add that I think that if you were to, and this hasn't been done recently, but if you were to poll geriatrics fellowship graduates on their confidence in assessing and managing elder abuse, I think you'd find that a large percentage aren't that confident. And even senior geriatricians, and I think we would all agree that if there is one specialty where this is a core component, it's geriatrics. And I think even geriatricians don't yet all feel confident in this. And so I think as academic geriatricians, you guys can say, well, that's something we want to focus on for our trainees. And for the trainees in the line, that's something that you want to make sure that you're confident in at the end of your fellowship. But we are starting that process. As Elizabeth mentioned, I'm part of the Geriatric Emergency Department Collaborative, and we just designed a curriculum that we're launching in the next few weeks or next month for emergency physicians on how to assess and manage elder mistreatment. And that was led partially by me, but also by Lena Macaroon, who's a close colleague and friend who's a geriatrician at the VA in Pittsburgh, who's doing a lot of research in this area and is really amazing. And we're also trying to capture best practices. We just published a paper about several months ago looking at the research. I'll tell a brief story. Do I have time for a brief story? Not really. No. So
People will hop off if they have.
Yeah.
To,
So
go ahead.
We did a systematic literature review on what's out there. Again, the part of best practices is seeing what research is out there and trying to compile the research in a systematic review. And we did this in the context of we did elder abuse and other folks did delirium and dementia and falls and medication prescription. And we all presented our findings actually here at a hotel near the airport. And even though he wasn't a geriatrician, even though he wasn't an emergency physician, Dan Matlock was invited because he's a cardiologist and was going to do something similar in cardiology. And I remember he pulled me over later and said, Tony, you obviously chose the right topic because there's almost no research. It was really easy, right? And so I think that that's part of the story, that we're hoping to publish more and we're hoping to establish better best practices, but we are still in the infancy of the field. And so we still believe that the best practices that we are teaching now, that we are trying to disseminate both from the perspective of lectures like this, from the perspective of in book chapters and in GRS, those best practices are likely to change. And we are definitely early in the process of learning. There is very little evidence-based literature to guide us. What we'll talk about a little bit more later today is just how hard it is to do good research in elder abuse. But we desperately need it. Interestingly, we were having dinner last night with Dean Krugman, and Dean Krugman said, one of the real challenges in child abuse is we've never had evidence to guide our practice. That their practice has typically always been sort of guided by a couple of terrible incidents that have sort of changed the way things are done. And we're in our infancy, but we recognize the importance of evidence. We recognize the absence of evidence, but the importance of evidence. And so the way that we're hoping to disseminate these best practices is through research and evidence gathering.
Thank you so much. It was a great presentation. Appreciate it. Thank you, everybody.
Sorry it was a little
for
long.
joining.
Sorry it was a little long, everybody. Started a little late.
If anybody wants to go with me to get coffee.
Yeah, let's